Well, thank you all for being here tonight. We're excited to be together as always, and hope you're having a good spring. I can't believe it's April already. And so I'm excited to share with you tonight about airway and some of the things that we're thinking about now and that we've been talking about and discussing around the country as we've been trying to expand our model of dentistry, but also of just healthcare. And so I'm going to be sharing with you some tricks that we have found to be very useful and simple, things that you can do in your office right away. And just for those of you that I can see, raise your hand if you're actively screening most of your patients for airway concerns now. So most are, it seems okay. Of course, we know that the ADA recommended that in 2017 for all in dental practice, but also it's so evident that there is a huge issue. Um, are you surprised by how many people you see coming in that have sleep problems and airway problems? It's a lot. And I know in about 2012 was the first time in my practice that we ever started screening on a regular basis. And so we kicked it off by using the Epworth Sleepiness Scale. And so I gave it to everybody that walked into our practice for about 6 months. And so we screened about 2,000 patients. And we found that over 400 of them were positive for a sleepiness, probable sleep apnea, or now as we would think about upper airway resistance problem. And so maybe 20, maybe 25% of the population wouldn't be a surprise at all. And I'm imagining that you're finding about that same kind of numbers. What I want to do tonight is start off by just discussing for just a minute the problem, and then we'll go into some thoughts about ideas and solutions. So let me share my screen. And as we're going along, Gina, if you don't mind, just keeping an eye on the chat area. If there's a question and someone's not able to ask because they're muted or whatever, just bring it up and we'll talk about it. I don't have a lot of material that we need to cover. I don't care how much we do. I really just want us to be able to have a good interaction tonight. But let me start with this one because this really struck me. Some of you know Mark Cannon well. He's been the president of the American Academy for Oral Systemic Health. He's a very dear friend of Laura and Gina's and mine. And he has been at Lurie Children's Hospital in Chicago as a pedodontist and researcher. He's on the Nobel Prize committee and just a brilliant genius. He's one of the top people in the world as far as expertise in the oral microbiome and gut microbiome. And so we just have the most respect for Mark, as well as being a very, very dear friend. But this was an email I got from him on January 1st, 2020, and you can read it. But essentially, his brother died on New Year's Eve of 2019. And he said the pulmonologist told him that his brother had died from sleep apnea. And then you'll see in yellow, it says the sleep test he was supposed to have done was denied by the insurance carrier, as then was, of course, the CPAP. They told me it was tragic and unnecessary. A CT showed massive brain necrotic areas due to oxygen deprivation, and he died at 59 years old. Imagine living in the United States of America and having that sort of thing happen where someone's actually seeking help and they can't get it because red tape is there, or maybe the physician that they see is saying you need to go get a polysomnogram in a hospital or sleep clinic, and the patient doesn't want to do that. In fact, let me tell you the summary of a study that was done of several thousand subjects, just to give you a concept of what the state of things is. There was a large study with thousands and thousands of subjects that took the Epworth Sleepiness Scale, the written test that tells whether you probably have a sleepiness problem that could be sleep apnea. Well, of that population, I'm going to boil it down and let's just say there were 100 that took that test. Of those 100 that all had high scores on their Epworth sleepiness scale, they were all recommended to have a polysomnogram. Of the 100 that were recommended that sleep test, 40 denied the accepting to do the test. So they dropped out. Nobody helped them. Of the 60 that did the sleep study in the hospital, all of them were recommended to wear a CPAP. So of the 60 that were recommended to wear a CPAP, 20 said, no, I'm not wearing a CPAP. So they dropped out of the study and the services. Of the 40 that agreed to try a CPAP, 20 brought it back and said they were CPAP intolerant, leaving 20 out of the 100 saying they would be willing to keep trying it. And that was all the care that they received. So you can see that even those that were screened well, only 20% got any treatment at all and probably weren't very compliant. And yet the state of the science or the art of sleep medicine pretty much falls in the category of you must get a polysomnogram and then you must wear a CPAP or we can't help you. And so that's where we enter because we can do so much better as health professionals. And so let's talk about that and how we can implement screening, but also care at a very high level, very effective level on the majority of people in a dental office. And so something that that Mark's brother could have had would have been a simple at-home test. And I'm trying to get this to forward and it's not. So let's see what we have to do here. There we go. So there you see under Mark's picture, you see a simple high resolution pulse oximeter. The cost of that unit is about $495. It can very effectively screen at a very high level of sophistication for airway problems, for oxygen desaturation, for heart rate excitement and acceleration that can tell us if there's a problem or not. And I'm going to talk to you in detail about that tonight. And in fact, I'm going to introduce you later tonight to the person who manufactures that and created that device. So I'm excited to introduce you to Craig Pickerel. Just to get this started for you that, aren't feeling up to speed on sleep medicine, it's not that complicated. Yes, there are many different kinds of sleep disorders. What we're talking about are breathing related or airway related sleep disorders. And so in that category of problem, then Rick Bonato, who is the CEO of Braebon Corporation and is an engineer who developed one of the top home sleep studies called the Metabite and the Metabite Junior out of Ottawa, Canada. He uses in his teaching this, what he calls wheel of death. And it goes like this. You fall asleep, and then as you fall asleep, your airway narrows, and you may begin to snore, which is actually pathology because it's a sign of obstruction, isn't it? At least partial or temporary. If the airway narrows to the point of collapse and you don't breathe for 10 seconds or longer, and your oxygen saturation levels drop from, let's say, 99% to 98 to 97 to 96, maybe 95, then after that 10-second period or greater, and that oxygen desaturation, you're having what would be called an apneic event. All right. And with that, or hypopnea, which is shallow breathing, then you're going to have lower blood oxygen levels to the point where it'll actually activate in the central nervous system an alarm that says, we're losing oxygen, we're choking to death here, we've got to do something about this. And so you'll switch from parasympathetic rest and digest into sympathetic fight or flight. And when that happens, then the adrenals are stimulated to release stress hormones, namely cortisol. And what that does is it accelerates the heart rate. and it will cause what's called an arousal from deep sleep to light sleep, or maybe even to being awakened. And so once that happens, then everything normalizes. Breathing resumes back to normal. The airway opens, the muscles relax, you go back to sleep, and then you repeat the cycle. So, depending on how often that happens, that would dictate the degree or severity of potential sleep apnea. So, we measure that very specifically, but I want to share with you a couple of simple terminologies that are used in sleep medicine that we should be familiar with if we're going to have conversations with sleep physicians and work in this arena. So the first one is what's called RERA. RERA means respiratory effort related arousals. And that means simply that you're having to work hard to to breathe, working hard enough that it's causing you to have an arousal from deeper sleep to light sleep. This can happen because of an apneic event, but it can also happen, we've learned, in shorter events that aren't full-blown apneas. And that's commonly seen in what we call upper airway resistance syndrome, which just basically means you're having trouble breathing through your nose enough that it's causing these awakenings, and it may probably cause you to convert from nasal to mouth breathing, which is really dysfunctional breathing. And so RERA is an important term for us that we'll talk about a lot. The second thing would be obstructive sleep apnea. So obstructive sleep apnea basically means in the back of the throat, which is collapsible like a straw in the posterior pharyngeal throat area. If that collapses, like what happens with snoring, but also with full blockage, if that happens for 10 seconds or longer with desaturations of 4, 5, 6%, that would be called an apneic event through obstruction, through a blockage of air being able to pass through the throat. That's different than what we call central apnea. Central apnea is where the brain center does not communicate with the respiratory center to make the effort to breathe. So that's not necessarily because of an obstruction, but because of some physical problem. It could be a brain tumor, it could be congestive heart failure, things like that can cause central apnea where you're not even trying to make the effort to breathe. If you have obstructive blockage and central apnea happening together, then those are called mixed apnea. So that's those two things together is called a mixed apnea. Hypopnea just means very shallow breathing. It may restrict the amount of oxygen that passes through the airway into the lungs. And together, obstructive sleep apnea, central apnea, mixed apnea, hypopnea, all are under the umbrella of what we call AHI, which is the apnea hypopnea index. So that's what sleep physicians are looking at when they're trying to determine what level or severity of sleep apnea may be present. And the numbers look like this. On an AHI, if the numbers that come back from the all-night report show that between 0 to 6 episodes on average per hour of 10 seconds or more and desaturation, less than 7 or 0 to 6 would be considered in a normal range. 7 to 15 episodes per hour on average would be considered mild sleep apnea. 16 to 30 episodes per hour average would be moderate sleep apnea, and anything greater than 30 events per hour on average throughout the night would be considered severe sleep apnea. So just remember these terms. And then there's one other, and that one other term is called RDI, which stands for respiratory distress, or it could be respiratory disturbance index. And what RDI is when you take the RERAs, that's the respiratory effort related arousals, and the AHI, and you combine them, and it gives you a score that's slightly higher typically than your AHI. Okay, so I'll show you where this comes into play in just a few minutes. So remember RERA, RDI, AHI, and we'll be able to have a good discussion about that. So all of us see patients every day coming in like this gentleman. So He's a middle-aged man. When you look at him, he kind of looks like the poster boy for sleep apnea. He's got a large neck. He's sort of overweight. His hair's all messed up. He looks like he just rolled out of bed when he came into the office. His medical history is high blood pressure, cardiac arrhythmia, and heavy snoring, which goes right along with sleep apnea. But then when you look at his teeth, his chief complaint is that he's chipping his front teeth, and he would like for us to restore his anterior teeth. But what I want you to note is on the porcelain on his teeth, particularly as we look at number 9 and below at number 23 area, you see that the porcelain is chipped and they match up facets just like you would see with enamel. And he's out protrusively edge to edge and even into crossover. So why would you go out there and chip your teeth? And the answer would be because you're trying to open up the back of your throat by bruxing forward. And so bruxism and sleep apnea go hand in hand. But also as we look at his mouth and have him open wide and you can't see his uvula because it's down his throat, he would be what's considered a Malin-Potty-4, a high level of soft tissue down the throat. Then we would look at him and say, could this guy have an airway problem? Could he have a sleep problem related to an airway disturbance or a breathing disturbance? That would be something that would be at the very front of our minds, looking at the damage, listening to his or looking at his medical history. And so what we're going to do is we could send him home tonight and do an overnight study, which we did. In this case, we did it with a high resolution pulse oximeter, but also looking at his AHI. And his AHI turned out to be 68. Remember, 30 is severe. So this is someone who is literally a heart attack waiting to happen. And so we referred him to the sleep physician. They worked him up. They did a polysomnogram, and he is now using a CPAP. But we very well may have, just through what we recognize there, have potentially saved his life. And this is something that you can do literally on a daily basis. So here's another example of the kinds of things that we've seen for years and years and years and years and never really knew what the problem was. So this gentleman comes in, you can see he's severely worn down his anterior teeth. So we did crown lengthening on the bottom. We put him in provisionals on the upper and lower anteriors, worked out the occlusion. While we were restoring him, I made him a temporary splint to protect him from grinding. He loved it so much that he ground holes through it within 2 weeks. So he was still actively, aggressively grinding. We completed his restorative work. And when we did, of course, we made him a night guard and very meticulously refined the occlusion so that it was just perfect. But when he came back for a 2-month post-op check, look what we saw. He was wearing facets on the interiors, now picking up posterior teeth interferences and excursions. And you're thinking, why in the world, after perfecting the occlusion, putting in a really well-refined splint, would he keep bruxing? And we never really knew the answer. And finally, in 2009, exactly at the time I was restoring this gentleman, or just had completed him, I read an article, and this was out of Baylor College of Medicine. And look what it talked about. It talked about sleep apnea, and it talked about bruxism and how prevalent that was with people with sleep disorders. And it says at the end of an apneic event that it may be accompanied by a number of mouth phenomena like snoring, gasping, mumbles, and teeth grinding. And I have to tell you, that was the first time that had ever come on my radar. And all of a sudden, it was like this big revelation of that bruxism is not just about malocclusion or poor occlusion, as we had been taught in dental school, but that it was highly related to airway disorders and the effort to open up the airway, even if it was at the expense of enamel. And in fact, it would be necessary. So what we had always historically called parafunction, that is a beside normal activity, like a bad habit, which was what we thought of with bruxism. Now, all of a sudden, we're realizing this isn't an accident. This isn't a bad habit. This is the body trying to protect itself and open the airway so that it can receive enough oxygen to stay alive. This is purposeful function of the body to protect itself. So not parafunction, but protective function. So when we look at this um, diagram that I'm showing you with the orange circle, I want you to see that there's really two things here. There's not just an orange circle, but behind that orange circle, there's also a white box. And I want to compare that to when we're looking at our patients today and looking at a broader view of not just what we're used to looking to at the teeth, the gums, but now looking in the back of the throat and throughout the mouth. Let me give you an example. There was a 21-year-old female TMD patient that was sent to me, and she has all the classic symptoms: sore muscles, clenching and grinding at night, morning headaches, chronic fatigue. But she tells me when I meet her that she woke up a week ago in the middle of the night in a panic because her chest was pounding and her heart was racing so much that she literally got in her car and went to the emergency room. When she got to the emergency room, they worked her up. They did an EKG, a number of tests, and they decided, and she was told that she was having a panic attack. And the emergency room physician gave her a prescription for Valium. So when she comes in to see us, you or me, then now we're thinking about TMD patients often are patients that have airway issues that they're trying to protect through this protective function that we call bruxism, clenching and grinding. They have excitement of stress hormones. They may have inflammation created by that. It's very common for them to wake up with headaches in the morning. So I would have to ask myself, in looking at any TMD patient, any patient with wear on their teeth, could they have an airway problem? So I asked this young lady, have you ever had allergies when you were younger? And she says, oh, yeah, I've had allergies all my life. I have bad allergies even now. I said, do you sleep well at night? She says, oh, no, I sleep very poorly. Do you wake up at night more than once? Oh, yeah, I'll wake up 3 or 4 times during the night. Are you tired in the morning when you wake up? Oh, yes. Are you tired during the day? Yes, I am. Okay, let's take a look. So sitting in the consult room before we ever went into an operatory, I said, I want you to do something for me, honey. I want you to open your mouth as wide as you can, and I want you to lift your tongue up as high as you can, and let's see what we see. I hope as you look at this photo that you see at least 4 problems that could relate to a systemic problem that can be very severe, called airway obstruction, airway breathing, and sleep disorders that can completely throw your body out of balance, that can cause all kinds of stress and inflammation, TMD. So as you look at her, she's lifting her tongue as high as she can. So she has severe tongue tie. You look at the border of her tongue, she has a scalloped tongue. You look in the back of her throat, her uvula is down her throat. So that's a Mallampati 4. If you looked at the arch, the upper or maxillary arch, you see that she has an omega shaped or narrowed arch, which implies, in this case is obvious, that her tongue does not go up and fill the vault of her mouth, but also implies a mouth breather. And then the other thing you wouldn't see is the edges of those anterior teeth on the right have wear all the way through the enamel into dentin on the top and bottom. And she goes out in that position and she rubs during her sleep. So those are all 1, 2, 3, 4, 5 red flags for a very possible serious health issue that we call sleep apnea. We sent her home for an overnight study with, in this case, a watch pat. It comes back and her AHI is 34, severe sleep apnea is 30. So she was diagnosed with a panic attack and she was given Valium. Would you want to give Valium to someone with severe sleep apnea? And the answer is absolutely contraindicated. So not only did she not get a good diagnosis in the emergency room, she got a diagnosis that included a treatment that could actually harm her. And so her problem is an undiagnosed severe sleep apnea. And I want to challenge us that we as dental professionals today are the gatekeepers of the gateway, and that is the portal, which is the mouth, but also all of the breathing apparatus, as we recognize, is right there in front of us. And so we have a tremendous opportunity as well as responsibility to look at that. So that's just a simple example of something that we see every single day. So what I want to do is talk about us together as dental centers for healthy breathing and sleep. And one of the questions would be, so how do we do that? If you're not doing that presently, or if you're trying to find a better way to do that, what are some simple things that we could do in our dental practices starting right away that we could do to provide a better service? And I would like to talk with you some about biohacking sleep. Biohacking, of course, in medicine is very popular, just trying to find advances or understanding how things work and what tricks we can come up with that might be innovative to improve people's health. And so I want to share with you what we've been working on recently and what's been working very well and what we've been using in our teaching as well. So first of all, of course, is simple screening. And so the Epworth Sleepiness Scale is used all over the world for patients to screen for potential airway and sleep disorders that would need further evaluation. And so I would recommend once you're ready to begin doing screenings, that you consider taking your whole practice over 6 months and screening everybody. This is one way to do it, and this is a wonderful general scale that's used all over the world. You can download it off the internet, and it's good. One that's very, very good, too, for men is the stop bang. And I want to show you just how many people there must be out there that are men over 50 that have sleep apnea or disorder or sleep disorder breathing. So there's 8 questions here. And if you answer 4 or more affirmatively, yes, then the odds are high or the risk is high that you may have sleep apnea. So listen to this. Here's one question. Are you a male? Yes. Are you over 50? Yes, that's 2. Is your neck circumference greater than 16 inches? Mine, I think, is 16 and a half, and I don't have a very big neck, but I would say more than 50% of men over 50 have a neck circumference greater than 16 inches. But look at this one. Do you snore? What percentage of men do you think over 50 snore? I think most of the women would say all of them. Or are you tired or fatigued or sleepy during the day? How many times we see men that come in and you ask that question, they say, yeah, but I'm 60 or I'm 65, as if it's normal to be tired at 65, just because of age. And then when you look at blood pressure, do you have high blood pressure? Are you being treated for high blood pressure? What percentage of men over 50 are being treated for high blood pressure? It may be 50%. And so we're looking probably 75% snore, 50% have high blood pressure, BMI more than 30. What I do is on the back side of this form, I have a BMI chart and I let them look at it. And of course, a pretty significant percentage would be in that range of over 30 BMI. And so you can see there's a lot of people out there that have a high stop bang score or a high Epworth sleepiness scale. So we start with that, very simple. And then if their score is high, then we're going to recommend a further evaluation. So how are we going to do that? Here's one way you could start that I really like a lot, and I don't know how many of you are using it, but it's an app that you can download on your smartphone called SnoreLab. A lot of people use this, and SnoreLab is very, very simple. It was free. I don't know if it's free now. It may be $5 a month, but it's not much. But let me just show you an example of how I use it. If I have a patient come in and we suspect a sleepiness problem, or they say they snore, then I'm going to, in the operatory right there, we're going to go ahead and download this app on their smartphone for them to begin using it tonight. Okay. And then the first night, I'm going to have them use it with nothing in their mouth or no treatment at all, just to get a baseline. So this is me on an empty mouth on Sunday, August 27th. And you can see as you look at the graph that the higher lines and the more orangey colors are higher decibels of snoring. And so then it also gives you a score. See the score in the little circle there that says 54. So that was my score that night. The second night, Monday night, I simply put mouth tape over my mouth to force me to breathe through my nose. Now, as you know, most people that snore through their mouths and loudly. But if you block the mouth and snore and breathe through the nose, it's much more difficult to snore, but also hopefully you're releasing nitric oxide from the paranasal sinuses and you're stimulating dilation of the nasal airway and down the throat and improving that patency. So the second night, Monday night, just using mouth tape, you can see how the volume went down significantly and the score overall went down by half. The third night, Tuesday night, I went ahead and put an oral appliance in. Now, this doesn't have to be a permanent oral appliance. You could use an over-the-counter or oral appliance, which is what I'm using with our patients now, as we simply test for results using this objective way of evaluating it. So on Tuesday night, using the oral appliance plus mouth tape, my score went down significantly to 12. And a couple nights later, by Friday night, my score was 7. And you can just look at the snoring disappear until there was literally none. Okay, so would mouth taping and an oral appliance be something effective for me for reducing snoring significantly? Yes. Would that also improve my airway? Probably. Probably it does, but we can go find out. And so to go along with this simple trick, then another thing that we use is a high resolution pulse oximeter. Now, what a pulse oximeter does, as you know, when you're doing sedation dentistry, is it monitors oxygen saturation and heart rate. And so if we want to do a good screening, we're going to use a high resolution pulse oximeter that's actually monitoring every second all night long. And then this particular one, which is called the SleepSat, and I'm going to introduce you to Craig Pickerel, who's the CEO of Patient Safety, which is the company out of Columbus, Ohio, that manufactures the SleepSat. Craig's going to come on the call on our study club meeting in just a little bit. But what they've done is they've created a software whereby on the right-hand side there, you see 4 graphs, essentially bars. And what you're going to do is do your overnight sleep study or screening, and then simply download this report and look where the arrows point to. So what we're looking at is this: when oxygen levels desaturate enough that it stimulates that sympathetic fight or flight response and you release stress hormones, then the heart rate's going to go up. And as the heart rate goes up, then the oxygen levels will go up. As there's an arousal, everything will normalize. You go back to sleep and repeat the cycle. So what we're looking for is how much of that is going on. So let me just show you, as I'm going to enlarge something here. The first box that I've circled in purple, let me enlarge it and show you what it shows you. So do you see at the top of the box, it says RDI? Remember that? RDI is what? It's a combination of RERA, respiratory effort-related arousals, and of AHI, apnea-hypopnea index. If you look at the bottom of this graph, on the left, there's an arrow that says 1. And under it, it says 2 to 4% desat RERA. See that? So that was what we were talking about before. And on the right-hand side, it says greater than 4% desat. That would be the same as AHI, but we're really not going to use the term AHI because we want to be able to screen this and get an idea of what's going on without getting involved with defining an AHI, because as you know, we in dentistry are not medically legally allowed to diagnose sleep apnea. So what we're going to do is we're going to evaluate through a screening process that's very high level without actually getting an apnea score that is telling us exactly what that is. But I'll say to you that greater than 4% DSAT is actually essentially the apnea score. But this has been designed for dentists so that we can do great screenings without being under the confines of saying, well, are we going to get in trouble for doing this? Is it okay for us to talk to the patient about what we found? And so here's what we're going to do. We're going to talk about RDI, and you can see here the 1 + 1 = 2. So in the middle of that graph, the RDI is 2, and we're down in the green, which is good. That means that we really don't have an airway problem related to stressful breathing during sleep. So we can report that to the patient. So then let me go here, and what we'll show you is the raw data on the left-hand side here. And you see on the left, it says SpO2, so oxygen saturation. That second line that's solid would be 90% oxygen saturation. The blue line is where the patient is during the night. So you can see he really doesn't drop below about 95% oxygen desaturation or saturation, which is good. On the bottom is the pulse. And so we want to be down in that 40, 50, 60 range. And you can see the pulse stays real steady overall throughout the night in a very low range. So that's really good. Now, the 3 columns on the right, let me explain those to you, because the first one on the left is what's called saturation baseline. That basically means when you get ready to go to sleep, what is your oxygen saturation? So normally when we're awake, it's going to be 97, 98, 99%. And that can be true even with people with sleep apnea. And so that typically isn't going to be one that we pay a lot of attention to as long as they're in the green. Okay, but then on the 2 right-hand ones, it says cycling time percentage and cycling severity. I think of this as what we call fragmented sleep. So if you go from light to deep sleep and you cycle light to deep about 5, 6, 7 times during the night, every 60 to 90 minutes you make that cycle, then you're going to spend a good percentage of your time in deeper sleep stages. But if you go from light to deep and then you bounce back up to light, and then you drop back down into deep, and then you bounce back up to light, and you drop down and you're bouncing up and down, that would be called cycling that is more than normal, okay? And that's what we're measuring here. And also the severity of that cycling. Is it, waking the person up? Is it a strong arousal? And so you can see here that it's down in 0%, 0 on both cycling time and cycling severity. So this person would be totally in a normal range. So this second one that we see here, if you look over on the right-hand side, you see that the RDI is 5. But then when you look at cycling time and cycling severity, there's a little bit in the yellow there. And this might be typical of somebody with upper airway resistance syndrome. In other words, they don't have sleep apnea. They're still in that 0 to 6 range, but they're having some disturbance of their sleep. They may be having some arousals from deep to light sleep. They may wake up a couple of times during the night. They may feel tired in the morning because they're not spending quality time down in that deeper stage of sleep. So this would be someone that you might see very often. That might be classic of your young, fit female TMD patient that comes in at 21 and says, I think I'm clenching and grinding. Sometimes I have headaches. I'm tired during the day. And they may come back with a report like this. Here you see another report, and look at this one now. The RDI is 9. So that would be equivalent to probably mild sleep apnea. But as you look at cycling, now we're getting into the red and even high red zone. So this would probably be typical of someone that would be the equivalent of mild obstructive sleep apnea. Okay, then we'll look at one more here and look at this one. The RDI is 36. Remember, severe sleep apnea is 30 or greater. And then look at the cycling times. They're essentially almost off the charts. And this was actually an individual that had congestive heart failure. And let's see, severe OSA, and had congestive heart failure. So you can very quickly screen and get a very good idea or guesstimation of what's going on. If you have someone in the higher range like this, I would recommend referring this directly to a sleep physician, and that's what we did in a case like this. In other cases, though, I want to talk about what we might be able to try as a little bit of biohacking before we make a decision about whether we're unable to be helpful or not. Look at what happens with the obstructive sleep apnea, with what's going on with the oxygen desaturations and the pulse. It's just like all over the place, erratic. And that's what you would expect. And of course, there's zero quality of sleep in some cases with that, and that greatly affects the overall health. So high resolution pulse oximetry has been something that's been studied and found to be very successful in screening patients that may have obstructive sleep apnea. It also has been useful to, in some cases, give us enough information where we don't really need to get more into more sophisticated testing, because we get the information that's very useful from this, and then we can go from there with some treatment ideas. So, whoops, let's see here. I just checked out of my presentation. So let me get back in here. Oops, what happened? Okay. Good, okay. All right, so this is Jim Metz. Jim is a dear, dear friend from Columbus, Ohio, who's been our mentor on this subject of high resolution pulse oximetry. He's been working with it for 30 years, I would guesstimate, and has developed this at a very high level as far as teaching and use with hundreds and hundreds of patients that he has worked with, primarily with oral appliance therapy, and finding that he's able to help a lot of patients that you wouldn't think you would be able to using oral appliances and high resolution pulse oximetry. So again, we're looking at oxygen desaturations and heart rate increases that may relate to stress during sleep. And so let's say that we have a TMD young patient come in, like the 21-year-old that I showed you earlier in the presentation, coming in with the classic symptoms. And the question that would go through our mind now is, could there be an airway problem? And so we're going to run our overnight high resolution pulse oximetry. Jim recommends, and this is what we do, that we would run a 3-night study. And so we'll use it 3 consecutive nights and get those 3 reports and compare them. But let's say this one patient comes in and we do this study, and here's the study that we receive back. And here's where the numbers all fall, and you say green, 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 green. So we're good. It doesn't appear that there's an airway or obstructive sleep problem. And so we'll begin to look at the other factors, malocclusions, joint problems, etc., and how we might address those. The next patient may come in and look exactly like the one that you saw before that, and we do an overnight sleep study and we get these results. And here you say, okay, there's something going on here. It looks like it could be borderline sleep apnea, maybe just upper airway resistance syndrome, but a lot of disruption in sleep and in fragmentation of the sleep. And so we're not really clear here, what exactly is happening, but we could use, considering that our options are a CPAP or something perhaps that we can do. What are some of the tricks that we've learned that can often bring those numbers down into the green zone? And so why don't we try a few things over a short period of time and see? So this is the Patient Safety is the company. SleepSat is the high resolution pulse oximeter. The cost for it is, I think it's around $495. So my challenge to you would be, this is a very inexpensive way to get a lot of great information on our patients, and I would really challenge you to order one. If you use a code that we've been using for a year or so, Wilkerson Lecture, they'll give you 10% off that. If you go into their website and download the order form and use the promo code Wilkerson Lecture, they'll give you 10% off. And so we'll ask Craig a little bit more about it when he comes on. But at any rate, this is a fantastic tool many top clinicians in dentistry around the country are using this as their go-to approach for doing their screenings. I have 4 in my practice because I like to send them out for 2 or 3 nights. And so I'll have them out most every night. Just using them over and over again, not only for this screening, but also, as I'll show you some of the hacks that we're going to use, how we will evaluate our success or lack of by redoing our sleep sats as well as our snore labs. And so I think once you begin to use this, now the other thing I would share with you is I said it's inexpensive, and it is. What I charge for the 3-night study is $95. So it's really nothing. But when we pay so little for it and we're using it weekly, maybe twice a week, you can see within the first month you paid for it. And then after that, every time you send it out, basically we're making $95 for the practice. But also it's super affordable for the patient. When I was using sleep studies, home sleep testing, then our costs could be anywhere up to $150. So we were charging about $295 for a 1-night study to get our HI and sleep position and some things that were helpful. But I found that in some states in the United States, you're not even allowed to use an overnight home sleep test as a dentist. So you'd have to order it. But this is something that you can use in your practice every day. And I don't know any restrictions for this. So I really think it's it's our go-to tool. And the top people that I know in our field of dental sleep medicine love this tool and are using it, not across the board, but very, very generally broadly being used. So this would be our recommendation or what you would use. So let's talk about some biohacks here and see what we can see. So on our IDM checklist, you see under airway and breathing disorders treatment, we have management and resolution. And under management, we list nasal breathing using Buteyko training, that is training people how to breathe nasally with their mouth closed, but also mouth taping is part of that Buteyko method that was taught to us by Patrick McKeon. Oral myofunctional therapy can be terrific when we're trying to get the mouth closed and breathe through the nose. If there are allergies, then we need to address those. So we'll work with an allergist or do allergy testing during that time. If there's other obstructions, we may be referring to an ENT. So let's take a look here at some of the things that we have learned and are implementing on a daily basis. This is Patrick McKeon, and he's been our expert at breathing. His book that was written, I believe, 2017 is called The Oxygen Advantage. I highly recommend it to you. It's really entertaining reading. I've had many patients read the book as well, and they love it. If they're into athletics, if they're into running, if they have asthma, if they have breathing airway obstructions, this is terrific for all those situations. So it also teaches you how to breathe properly through the nose and to build up CO2 and deliver oxygen into your cells. And so in that book, he talks about correct nasal breathing and that mouth breathing is dysfunctional breathing. He talks about breathing very gently and slowly through your nose and then actually holding your breath and then breathing gently and slowly through your nose, trying to build up CO2 in the bloodstream and deliver oxygen into the cells throughout the body. And so that's part of what's called the Bohr effect. And we could go into more detail on that. But anyway, that's very valuable information. And that leads us into a trick that Patrick showed us, and that is mouth taping. That if nasal breathing is physiologic breathing and mouth breathing is typically what happens when someone has nasal obstructions, often due to allergies as children, that we will be forced to reconvert to mouth breathing. And even if the allergies disappear, we outgrow those, the habit of mouth breathing very often, if not most often, will continue even for a lifetime. And so we understand that mouth breathing is breathing dirty air, bypassing the filtration system, going right down into the lungs. And so you're seeing a lot of press now, and even a lot of marketing for mouth taping. There's all kinds of different ways that you can keep the mouth closed. What I've been using is very simply Henry Schein paper surgical tape, and you can get 12 rolls for $12. And so it's $1 a roll, and I literally hand out probably 2 or 3 rolls a day all year long, as we have just conversations about nasal breathing, even for people that don't have issues, but who want to emphasize the release of nitric oxide from their paranasal sinuses to dilate their airway, to kill bacteria, and to dilate all the way through the respiratory system, and hopefully even into the bloodstream. And so we know how healthful the release of nitric oxide is. And besides eating foods that are rich in nitrates, then nasal breathing is another way of building up nitric oxide. Supplementation can also do that well. Cutting down on sugars can also do that as well. So we will start our conversations with patients about improved breathing and improved sleep by talking about mouth taping. Now, of course, if someone can't breathe through their nose, this isn't an option. So I would say to someone who's not sure, I'll give them a roll of tape. I'll show them how to put it all the way across beyond the corners of their lips. And then I'll show them, even as I put it on myself, that I can open my mouth if I want to without really much effort. So there's no danger of mouth taping that they're going to suffocate. But also I'll say the first night, why don't you put it on about 30 minutes before you go to bed, and just make sure you're comfortable. If you feel phobic, having the mouth tape on, then don't use it. But I find that most people find that they breathe even better, that if they have congestion, it starts to improve when they mouth tape. And so I think that's what you'll find as I speak with a patient. I'll say to them, but try it. And I don't want you to do it unless it's comfortable. All right. So that's a great trick. The other thing that we want to do, we talked about management protocol where we can increase the vertical airway, we can increase the horizontal airway, we can try to keep the jaw from collapsing, the tongue from collapsing, and by forward posturing the mandible. And so there's strong evidence in many cases that an oral appliance can work almost as well as a CPAP for dilating and maintaining an airway. So if I'm not sure if opening the airway is going to improve, let's say, sleep apnea, then I'm not going to make a $3,000 appliance for somebody to experiment with this. What I'm going to do is I'm going to buy an over-the-counter appliance like this Quiet Lab. You don't even have to boil and bite it over the teeth. You just put it in the mouth. You could put this over Invisalign trays if you were doing Invisalign and you wanted to forward posture the mouth at night for someone that has an airway problem during sleep. But I'll use this along with mouth tape for a short period of time just to see what kind of results we get. So I'll mouth tape. I might try to educate the patient more on nasal breathing and some of these things that we've learned from Patrick McKeon. We'll send them home with an over-the-counter oral appliance like a Quiet Lab. I might give them a sample of clear nasal spray, which is xylitol, that will kill bacteria and dilate the nasal airway. I might give them a little nasal dilator, such as a mute nasal dilator. There's many different kinds, but I may give them that just to open up the nasal airway, to dilate the nasal airway with the nasal spray. Another approach that I used for many years was a MyTap, which is a boil and bite, and it has a stem, as you see, coming out protrusively that the patient can actually turn the dial to move the mandible forward and back if they want to adjust it themselves at home. The Quiet Lab one is also adjustable as far as moving the jaw forward and back. So these are really inexpensive tools, but what we do with those is we will say to a patient, okay, here's what I want to do. I had a patient yesterday I'm going to tell you about. She came in referred by a sleep physician. The reason this sleep physician refers to me as a dentist for oral appliances is because I've made a commitment to her that I will not place an oral appliance in someone that's a permanent oral appliance until I can demonstrate that it will be effective in reducing their sleep apnea. So how do I do that? So I will have them use the Snore Lab. I will do a 3-night study with the sleep sat, and I'll say the first night, what I want you to do is sleep with an empty mouth. The second night, I would like for you to put paper tape over your mouth and sleep with the paper tape. The third night, I'd like for you to put the oral appliance in with the paper tape and measure what happens then. We'll have you return it. And then I want you to go ahead for another 6 days, so a total of 8 days. I want you to go ahead and use that approach every night if you're comfortable, and then come back in and we're going to look at your Snore Lab results every night for those 8 days. We're going to look at your sleep sat results for those 3 nights. We're going to ask you how you're feeling, and then we're going to make a decision on whether we feel an oral appliance would be option for you to use long term. I also can communicate this with their sleep physician, which they really like, that we're trialing this to make sure we're on the right track and that we truly can help them. Now, the other thing is we don't want to just manage people. So in many cases, particularly if they're someone that's willing, then we would be looking at other ways of expansion. So can we expand the oral airway? Can we expand the upper airway, the posterior airway? Do they have a tongue tie that could be released that would help with breathing and more appropriate positioning and swallowing? And so those are things that we would like to do, but we can demonstrate through this whether we can work with this airway and improve it through using a dental approach. Another thing that I've used quite a bit is this Medcline pillow. This is something that you can order online, and the Medline pillow puts you in an upward posture, which is helpful for apnea, but also for gastric reflux. So as you may know, a very high percentage of patients that have sleep apnea also have gastric reflux. Our sleep physician colleagues would say, well, you know why? It's because when you're trying to breathe and your airway is obstructed, then you create a reverse or negative pressure from the abdomen coming up, and up come the acids and the gases from the stomach. When you use a Medcline pillow and you sleep on your left side, as you can see in this diagram of this man sleeping, the esophagus comes out of the stomach on the right side. So if you sleep on your left side, it's harder to have gastric reflux than if you're sleeping on your back or on your right side. And so that's something that can be very helpful to combine improving obstructive sleep apnea with improving gastric reflux. So many studies have shown, and I could show you a number that talk about how oral appliance therapy can dilate the airway, and we can show that through our images. There are studies that have been published in the medical journals showing how oral appliances versus a CPAP have comparable efficacy in treating the problem. And so that's all good. Hey, is Craig on the call now?
Yeah, I'm here.
Okay, Craig, thank you for joining us. Everybody, I want to introduce you to Craig Pickerel. And Craig is the CEO of Patient Safety that makes the sleep sat that I've been talking to you about. And so, Craig, welcome and thank you for joining us. And thank you for the wonderful work that you've done in our behalf, working, I know, closely with Jim Metz and what he's been seeking to do with his appliances, but also in managing airway sleep problems, monitoring with the sleep sat. So I kind of went through with everybody, Craig, before you got on about the sleep sat, but could you tell us a little bit about how you developed it and also the software that we're looking at?
Yeah, so my partner, Dr. Lynn, he's kind of super smart guy. He's got like 80 patents, and he uh, his brother's like a software development guy, and he's a pulmonary critical care person. And so the hospital I started my first sleep lab in, he was in there already, and he was using oximetry to screen for sleep apnea and kind of found all these patterns. I used to print these strip charts out of the back of the oximeter. And so he would send people to the sleep lab and say, this person has Cheyne-Stokes respiration, or they have this or that. And I just thought, the first time he would send somebody, I just thought he was crazy. And he was always right. And then I was
Uh-huh.
like, how do you know that, And he had just learned that these patterns were, he would see them on the strip chart. And so he wrote some of the early papers in the 90s and 2000s on patterns of sleep apnea. And he's super smart as it relates to respiratory physiology. So kind of our secret sauce is really detecting the patterns of which is now called endotypes, but he was kind of the first one to talk about these different patterns. And so I think some of our secret sauces, we wanted to um, differentiate different kinds of patterns that you can see on oximetry. And
Mhm.
one of the real knocks on oximetry when we started was it misses cases. So we really wanted to have really sensitive detection and highest resolution oximetry. So he worked with the engineers at Minolta to help develop the first high-res oximetry, truly high-resolution oximetry. And then since then, we've worked with another company on the sleep sats. So, the secret sauce, we think, for mild endotypes, which is, UARS, they call it low arousal threshold,
Yeah.
is to kind of have an oximeter with real short averaging time and
Yeah.
also store to the 1/10% so we can see the pattern of desaturation and resaturation, which you really lose on most oximeters because the desats are pretty mild, 1 to 2% or two
Mhm.
to 3%, and you don't really see that if the averaging time is longer. So, you
Mhm.
know, we believe that, kids and people earlier on in the disease, we used to catch people when they were Pickwickian and really sick at end of life, but really now dentists are doing such a great job of screening their patients. They're seeing people just earlier on that their airways, their mouth breathers or, all
Yeah.
the things you just talked about in your protocol, and they're identifying where that obstruction is. But, in your teens and 20s and 30s and even 10s, these things present differently on oximetry. And so
Yeah.
we really want to ferret that out so that you can, you know, see those patterns and treat those patients earlier in their lives instead of just waiting until they're real sick and, the
Right.
autonomic systems are burnout. So, our oximetry detection is pattern based. And so, you know, anyone, I'm getting old now. So I think about like when I was in college, we all had spent all of our life savings on a sweet amplifier and an awesome set of speakers, right? So
Yeah.
so I think of it like that. We have to have, you wouldn't have like a crappy pair of bookshelf speakers with an awesome amplifier. So we believe that you have to have high resolution oximetry and pattern detection so that you can find all these cases, different kinds of cases that you're
Right.
gonna run into. So
Tell us about developing the software here, and why it's designed the way it is.
yeah, so we just didn't want people to have, I think in sleep medicine you can walk around with a bag of hammers and everything's a nail, is what I say. So
Mhm.
so we like to highlight that, there's all kinds of different kinds of patterns that go on. So you have nocturnal hypoventilation, which is so the first RDI indicator is really the primary one for sleep apnea. And so I
Right,
call it left side events or are the um, endotype of UARS or
right.
and so the 2 to 4% DSAT with a pulse rise of 6 beats a minute is a real mild DSATs with an autonomic response. So those are, the low arousal threshold endotype. And then the right side events are, more significant 4% DSAT events, which is
Mhm.
kind of the Medicare rule.
Yes,
And so those are just more overt events. I'd say most people would catch those. And
right.
so, but as you titrate events, they become shorter and milder. So they move from the right side to the left side as you're titrating them. So I always think that in titration, eventually the left side events become important for a complete titration of an oral appliance or any kind of therapy. Want to make sure we're getting rid of all of the events.
Yes.
The
Yeah.
second indicator is more like nocturnal hypoventilation. So the first pattern is like where you go around, you stop breathing, and then you hyperventilate. You
Mhm.
blow off your CO2 and have an arousal as you're doing that.
Mhm.
When you do that, your respiratory system wants to rebalance itself, so it wants to get more CO2 again because you've overshot and blown off too much
Mhm.
CO2. So then that allows for your airway to recollapse.
Mhm.
So the pattern we're showing is the repetitive pattern of desaturation over and over. So one
Mhm.
desaturation I don't really think is abnormal
Mhm.
because it's a sign of a healthy airway if we have one event and then we regain stasis, right?
Yeah.
But
Mhm.
an unhealthy person would re-enter because they overshoot and their airway instability is so one event caused the next event, caused the next event. So
Mhm.
so they call that the loop. In a time series graph, it's like DSAT, resat, DSAT, reset. And then in the milder endotypes, we see it in the pulse signal where there'll be a pulse spike, pulse slowing, pulse spike, pulse slowing, pulse spike. So you can have that same pattern of autonomic instability, which is caused in younger, healthier people. You'll see a lot more on the green pulse graph of that
Mhm.
pulse instability. And
Right.
so we've seen dentists that just titrate that away too. So one of the
Yeah.
things that's secondary to airway instability, but in healthy people, they'll have, early autonomic response and their DSATs are really tiny. So,
Mhm.
but the second graph is nocturnal hypoventilation. So in the absence of that cycling I talked about, some
Mhm.
people due to obesity will have a real prolonged DSAT. And so that they call that like an overlap issue. So if someone desats slowly to 84% per se, you would
Mhm.
not be able, and an autopap also would not fix that.
Mhm.
So usually what they would do is put someone on autopap or oral appliance and supplemental oxygen
Mhm.
because they have a secondary issue where their obesity pushes up on their lungs and
Mhm.
restricts their lung volume, causing a secondary desaturation. Those patients will often also have sleep apnea, but we're just trying to call your attention to the fact that there's
Mhm.
other things that can go on. There's other kinds of patients.
Mhm.
The
Right.
third graph is more just the percentage of the night that they're in that airway instability where they're desatting, resatting, desatting, resatting. So the percentage of the night that they're repetitively having DSATs. We're going to roll out a new report here in about 8 weeks that'll also have an autonomic or amount of time the autonomic system is in cycling also. So you'll have sat cycling and autonomic cycling. So usually if the autonomic cycling is really high and the sat cycling is low, that means they have low arousal threshold. And if the sat cycling is high and the pulse cycling is low, then that's more of the Pickwickian, really sick patient whose autonomic system isn't responsive. They might be on beta blockers and that kind of thing. So they'll have deep DSATs and not very good autonomic response. And then in the middle, where they have the same percentage, is kind of normal sleep apnea, kind of middle-aged male, my age, 50-year-old, So, and then the last one is just the severity of the DSATs. We're also going to be adding hypoxic burden very soon, but that was our precursor to hypoxic burden, was to show the severity of the DSAT. So if that DSAT is really high and the RDI is low, often that'll mean that someone might have severe REM sleep apnea. So they'll have real deep DSATs, but only during REM. And since those only happen every 2 hours for a half hour, your RDI can be relatively low, mild or moderate, and your DSATs can be extreme into the 70s. You don't see these cases that often, but we're trying to draw your attention to it when it happens, so you don't think this case is mild, because the case is really pretty severe, but the RDI can appear mild. So those are kind of like the furthest left one is the main one you worry about, and the other ones are just supporting things or to draw your attention to something else that might be going on.
So you can see here with this case that Jim managed with an appliance that they went from an RDI of 24 down to an RDI of 3. And
Yeah,
that this is now following it for 15 months. And so obviously the dilation of the airway was very successful in dropping not only the RDI, but also the cycling severity
yeah.
disappeared and the time disappeared, the percentage of time disappeared. So I spoke with one sleep physician, Craig, who I referred to, and I said, "Who do you want me to refer to you?" And he said, if their AHI, so we'll say RDI, isn't above 30, you just treat them. You can treat them as well or better than I can.
Yeah,
But if they're above 30, then you can send them to me and we'll need to do a full workup because of so many factors that we're not even knowledgeable of
yeah.
that relate to all these different sleep disorders that are many, many types. And so we're really looking at breathing disordered sleep in this case. So you see how Jim took someone that you would say had RDI of 24, so that would be comparable to moderate sleep apnea,
Hmm.
and was able to take them down to normal. What I would say is that what I've done is taken these kinds of cases like on the left. I would be comfortable since this patient's probably not going to have anything done, without our assistance. I would be very comfortable to do mouth taping and a trial oral appliance and nasal dilation and try that for a week or two and reevaluate it and just see if we're moving in the right direction to say whether we might be involved. But if they come in and they're in the super high red zone, especially in the RDI, then we're just going to refer them. But that's a super highly sophisticated screening that we're doing that they probably wouldn't have had done otherwise. And I'm thinking about Mark Cannon's brother, the one who never had the testing, never had access to it, and ends up dying without, ever really having the opportunity to get a diagnosis and treatment. And who knows if he could have been helped through just the very things that we're talking about. So, thank
I
you,
think
Craig,
I
for
think
that.
they
Go
yeah,
ahead.
the ADAs, I think the ADAs, dentists are really saving a lot of lives, because if you take seriously screening your patients who are not going to get asked by their primary care doc,
Yeah.
you're going to help a lot of people, certainly improve quality of life, and occasionally lengthen somebody's life,
Yeah.
certainly. So
Definitely.
that
Definitely.
previous slide, I can show you the airway.
Oh, sure.
That so this Yeah, so you see the green, that pulse. So go one more slide later.
Mm. Oh, that?
Yeah.
Yeah.
So you
Here.
see that pulse underlining. So that is autonomic cycling that we're underlining on the green right there that you're see the
Mhm. Yeah. Oh, the
underlines.
dots. Yeah.
We now
Oh,
are starting to put
lines.
boxes around them, but and then up above, you have the SpO2 cycling, but you can see that the SpO2 cycling causes autonomic spikes, and
Right.
that's why
These
we,
go
you know,
together.
they often will mirror each other. But in the younger, healthier people, you'll see, you know, a really thin SpO2 is much thinner. The DSATs are real mild, even
Yeah.
don't even get underlined if they're real young and healthy, but you can see
Right.
they're a little thicker, but their pulse will be like that all night long or even
Yeah.
worse.
Yeah. Yeah.
And, you know, if that's supported by, you know, they have their mouth breathers or retrognathic, their posterior
Mhm.
airway space is small and they're having all kinds of arousals, then those people are really good responders a lot of times to treatment. And they're not going to test positively on HST, but I've just seen them helped by dentists so often
Yeah.
that,
Yeah.
you know, it's a real lifesaver. Some of these people are having jaw clenching, they're messing up their teeth. You know, I probably
Mm.
could have saved myself a lot of money if someone in my 20s would have
Yeah.
told me
No,
all my teeth clenching was probably just trying to
airway.
reposition my airway
Yeah.
all night, you know?
That's so true. And you know, in the original discussions going back 10 years or more, it was all about sleep apnea. And now, as we're observing on a daily basis, particularly these younger patients, we're seeing that sleep apnea is really the tip of the iceberg. But below that is probably a lot more upper airway resistance syndrome than sleep
Yeah,
apnea. I
right.
would say so commonly in our society, who can put a number on it, but you know, we may be looking at 40 to 50% of people in our society that have a compromised airway during sleep. And so, you know, that really is a great opportunity for us to be on the front lines. I've given you in the chat a download that you can see kind of what our protocol is that we use in our practice. And so this gives you not only the things that we do and some of the sleep hygiene, you know, ideas that we'll share with patients, but also the sequencing of our appointments and how we handle that. So I'm going to stop sharing right there, and we have maybe 10 minutes left, but let me stop sharing and get out. And what I'd like to do is just spend the last few minutes talking. So, any discussion or questions that you all have for me or for Craig?
I
Let's see.
think you answered a lot of the ones that came through, Dr.
Okay.
Wilkerson. But one person asked if the pulse ox that you're using works on all skin tones.
Yeah, so the one that we just came out with just got FDA cleared recently. So that they had to show um, the skin tone. So they have the darkest dark skin and the lightest light skin. And they, so everybody who goes through the blood DSAT lab over the last, you know, since maybe 2022. I know 2023 when the testing went for the sleep stat that they had to show skin tone. So you have to, I think it's 16 patients now, but it might have been 12 at the time. But you have to have the darkest dark skin and the lightest light skin, and then a grouping in between of those patients. So yes.
Okay, thank you. Um, and then any research on tori removal and improved sleep and comments on that, Dr. Wilkerson?
I've heard some comments on that, but I haven't seen any larger studies on that. I've heard, you know, anecdotal observations of surgically removing palatal and lingual tori that were large and saying that it made a huge difference. I haven't done that with any patients in my practice. Has anybody on the call done that or seen that? Okay. That would be a great area for more study.
Mm-hmm.
Certainly takes up some volume, so that may be important for some.
Mm-hmm. I think that's about all of the questions that we have in the chat. Anyone want to unmute and ask questions? Or it was a great discussion, a lot of positive feedback in the comments.
Good. Well, yeah, please speak up if you'd like. But Craig, thank you for creating a tremendous service for us. And, I gave everybody the link to your website and told them that they would, get a 10% discount if they use Wilkerson Lecture. And
Yeah.
you've been very gracious to do that wherever we've been. And you also are modifying sort of the approach. We just received really a modem from you that the patient puts on their bedside and it instantly gives us a report. You want to just comment on that?
Yeah, so the new SleepSat's a BLE, and so one of the frustrations with the original unit is if a patient didn't wear it right and they would bring it in, there'd be potentially no data on it or not enough data, and that's frustrating for the patient and the provider. So the new SleepSat BLE, we worked with a company that does cellular modems to automatically connect to the SleepSat device. So it sends the data up to the cloud real time so that in the morning you get the report will appear in your portal. So the benefits of that are that you can know if you didn't have enough data and just let the patient know, wear it another night, and then re-educate them or it didn't work right, and kind of troubleshoot that, and then avoid the frustration of not enough valid data on the test. So that's nice. And then it also has we added some things where the watch will vibrate if it's the probe comes off, so that hopefully they'll put the probe back on or switch another finger. So we're also trying to, there's a couple of things like that we think will improve the amount of valid tests because it'll alert the patient what's happening and they can fix it real time while they're wearing the device. So, we're pretty excited about it. We didn't want an app. I know a lot of people have we didn't want the only thing to be an app. We're going to come out with an app in a few months, but we wanted the first thing to be a cellular modem because I think it's a lot to ask people, your staff to troubleshoot an app. And if the patient doesn't do it right, or their phone isn't that sophisticated and it doesn't work, and it just can be frustrating, I think. So, we wanted something that always worked.
Yeah. Well, that's great. Well, it's been so useful to us. One of the things I found in lecturing was I would go to, Mike McDivitt, I'd go to Georgia and lecture at Hinman last year. And in the middle of my lecture about doing sleep studies, someone raised their hand and said, "We can't do that in Georgia, legally." I think maybe
Right.
they changed it, but I mean, so you've got 20 slides to talk about something that no one in the room can do. But
Yeah.
also there was also that conflict, which was, okay, I'm going to do a sleep study and it's going to give me an AHI. And if it's above 6, then I've got to send it to a sleep physician to get an interpretation so I can actually talk to the patient about it. And
Yeah.
so the expense, would add up to a significant amount that we had to pass on to the patient. And I was wanting to run these things like regularly, and it got to
Yeah.
be so that I couldn't ask the patient to pay $300 now and in 2 weeks and in another month. And, it just became a burden. This has solved that problem. And I think it helps us to scoot around a little bit the whole apnea discussion or the medical legal issues that are silly, really, but are maybe territorial. And so the main thing is to be able to help people. And so y'all get the Snore Lab, do that for yourself. Get a SleepSat, get some tape out, use trial oral appliances and experiment with this. And I think you're going to get really excited about it. I have patients coming in every day saying, let me show you what's happening on my, store lab, and how it's just been dead quiet for the last month since we did, these things. And so it's really fun. And patients are so appreciative because they've been through the experience where the physician didn't have 5 minutes for them, and didn't really explain things to them and help them understand, which we're doing. And it's just so much fun. I am having the best time of my life. So I want you all to as well, and to be able to start really intervening and making a huge difference here. So you have that protocol there in the chat. We have an online course that you could take if you're interested. We're going to be doing other things, and we've been kind of doing more outreach now, and speaking at places like Pankey and Dawson and Seattle study clubs and those sorts of places. And that's been a lot of fun. So we'll try to keep posted, what we're doing and where we're doing, and maybe we can connect that way as well. Or if you have something you would like for us to come do anywhere around the country, that's our commitment. I will share this with you all. I haven't told anybody else except my wife and a few people, but I'm planning to retire from full-time practice at the end of the year and just concentrate on teaching and sort of consulting, with a sleep physician and Dr. Brian Shaw, who's the TMJ maxillofacial surgeon that I work with and does orthodontic surgery. So I'm real excited about that, but just spending more time investing in teaching and writing and some things like that. So all great. Laura's out teaching tonight, so she couldn't be with us. Thankfully, Gina could be. So thanks for being with us, Gina. And is there anything else, Kim, before we sign off?
No, I think we're set.
Okay, our next study club meeting will be on June 4th. And we actually have an entourage of dental hygienists that have been implementing a number of these things that we've been talking about, doing a lot of salivary testing and other things. And they're going to report to us what they're doing in their practices successfully as at least part of the program for 2 months from now. So bring your dental hygienist along with you in 2 months when we have this gathering, if you're a dentist and your dental hygienist isn't involved already. You dental hygienists, bring your friends, and you can have a little study group party together. So anyway, until then, thanks for being here tonight. We had a great group of around 100. So good job, everyone. Thank you for taking this time out of your Wednesday night, and we'll see you in June.